Welcome back to Medical Associates Health Check. Today we're talking about breast cancer screening. Unfortunately, Dr. Bristow couldn't be with us today, so I have Dr. Olivia as our guest. So, Liron, you're going to be my co-host today.
Thank you. Thank
Thank you so much for coming on. So, I know we've started this new initiative at Medical Associates because we had this thought process, and I think you agree with me that breast cancer screening isn't effectively done maybe in Trinidad and Tobago, or it's not, the uptake isn't there. So we want to create essentially a one-stop shop where you come, you get seen by yourself, they get their tests done, they get their biopsy, and within a short time space, we're trying to get somebody diagnosed and on a management plan so that anxiety or fear that you get with getting your test and I'm not sure if I have cancer or what does this lump mean sort of is eliminated because we don't have to wait 2-3 weeks to find out what's going on.
Yeah, is
Of course.
so you could have screening and then you could have diagnostic testing. It's two different entities.
Yeah.
Screening is the ability to pick up something before it becomes clinically relevant.
Right.
So meaning that you have no breast lumps, you have no nipple discharge, you have no issues with the breast, but you go in for this yearly screening to see if there's an abnormality in the breast
Or there's
structure.
a change that you haven't felt or seen.
Exactly.
Yeah.
Versus diagnostic is that you have a lump, you have a nipple discharge, you have a change. That's diagnostic testing. That's the realm of trying to get a diagnosis within a reasonable time.
So as a population, we tend to be reactive rather than proactive.
Exactly.
And that's probably why screening isn't a big thing here
That's
right now.
actually a really important topic.
Yes.
Point.
So I'm going to ask you a little controversial topic. Bristow's not here, so I have to represent him.
Yeah, definitely.
So are men part of the problem in terms of, do we put too much pressure on women? Are there too many societal pressures on women? And do men contribute to that?
I think women's responsibility has significantly increased. I mean, not just from a family perspective, but also in a financial aspect of things.
Right.
So I think their life responsibility has significantly increased. And rightfully so, I think the aspect of a male figure should always be supportive and reminding the female counterpart that they need to do the screening aspect of things. So from a perspective of that's where I will see that a man aspect might be. But to be directly causing breast cancer, definitely not.
I wasn't trying to imply that there was a cause and effect here.
Yeah, but definitely I think a guy can be supportive.
Okay.
Not just in matter of seeking screening, but also being aware of herself, clinically examining herself, reminding her, if there's an abnormality, discussing as a couple, and then seeking screening together.
So what you're saying then is men can be part of the solution.
Definitely. That's probably a better way of saying it than men being part of the problem. I think I'm already, I feel like I'm on the back foot already when you come with the approach of saying men being the problem.
Were you feeling attacked?
Yeah, we're feeling attacked to an
Sorry.
extent.
I'll take it back.
Yeah,
Men
but I
can be
think
part of
definitely
the
we can be part
solution.
of the solution.
Okay,
Yeah.
Great. So what we're trying to do is create this proactive approach to your health, and women and men often don't see the importance of having that regular checkup.
Yeah.
But let's talk about it.
So I think it's all about risk stratification first, because you can have two main groups. You can have a average risk, which is someone walking on the street in terms of their screening, and then you can have patients who are high risk.
Right.
Average risk is just basic. You have no strong family history, you don't have any previous history of breast cancer, no previous history of any abnormalities in the breast. Versus high risk patients, they have a family genetic issue, they had exposure to radiation, they had breast cancer before. These patients fall into the high risk group. So for the average risk, the age for screening is at age 40.
Yeah.
For the high risk group, I wouldn't get into the great detail, but sometimes you can start screening as early as age 25 in patients who have a genetic mutation.
Yes.
So you start with your MRI of the breast. And then patients who have like high-risk lesions to the breast, you can start at age 35, or family history, start at a high-risk family history, start at age 35 where you actually do your mammograms and your MRI scans.
So you have, because we talked about this, when women have dense breast tissue, you were looking at mammograms from the age of 35 because it's better than the ultrasound.
Yeah. I mean, the standard is, I don't want to skew the topic, but the standard is 40.
Yeah.
35 is only patients who have fallen into that high-risk group you will start at mammograms.
Right.
But the density breast issue is really, you have 4 categories of density to your breast. So your breast is made up of fatty tissue and fibroglandular tissue. The more fibroglandular tissue you have, the more dense your breast is.
So just to break it down, fibroglandular tissue is breast tissue.
Yeah.
Just so that everyone understands.
So that breast tissue can be more than fatty tissue, and that's where we categorize it. So you have A, so you have less than 25% of breast tissue.
Yeah.
Then you have B, which is 25 to 50%, and then you have C, which is less than 75%, and then you have D, which is between 75 to 100%. So obviously, if you have more dense tissue, more fibroglandular tissue, more breast tissue, you need that probably better quality mammogram machine, I would
Sure,
say, and
yeah.
that's where the 3D mammogram comes in.
And that's why we have that. So
Yes.
we invested in that last year because I think we thought it was very important.
Yeah.
Because it gives you it. Now it's important because everyone thinks that there's like this 3D model that's created.
Yeah.
It's not quite like that. It's just that the pictures taken in different angles
Yep.
create that 3D picture.
Yep.
And that makes it easier for us to do things like biopsy if we need to, see lumps that you wouldn't have seen in the previous technology. Is that correct? Or
Yeah. So what it really does is it goes along a path where it takes multiple pictures, so multiple slices, versus the digital mammography in the past will take one picture.
Correct.
So everything is superimposed. So now you can see in different planes, different levels of the breast, you can see if there's an abnormality. We know it increases the pickup rate of breast cancer by between 1 to 4 per 1,000 women. And it also reduces something that is important, which is called the false positive rate. So any test that you do can give you a false positive, saying that there is something there, and in actual sense there's nothing. So 3D mammogram actually reduced that by 15 to 20%.
15 to 20%. Okay.
So, and it is the standard now. So patients who have density breasts C and D, they should have a 3D mammogram. Patients who have A and B, they can have the regular mammograms. But the recommendation is if it's available, you should still have the 3D mammogram. So 3D is the standard now.
Okay, great. And that's an international standard. So we are keeping up with that here in Trinidad and Tobago, which is nice. Now, women, let's talk on why women don't go and get the mammogram.
Yeah.
Because the uptake is pretty low, if I'm not mistaken.
I think even before we start with looking at the patients, we should look at ourselves as physicians. I think we need to educate ourselves what the standard is, why it should be done. And if we know the knowledge about the issues that we're about to discuss, then you can give that out to the patients.
I agree.
And overall, it could improve the pickup rate on patients going for screening.
Definitely.
So some of the factors with mammograms is one, what age should you screen? And in 2023, there was a worldwide international standard that is 40 now, because we know in some studies, the American Radiology Society in 2023, they actually found that there was a 66% reduction rate in breast cancer mortality in patients who had mammograms.
Right. And
so
I think that's
mammograms
something,
are important.
Yeah, we've never really touched on those kind of statistics before. And while I know mammograms are important, I've never really thought about it in that context. So that helps. Thank you.
Yes, it reduces breast cancer, mortality, dying from breast cancer. That's what that means. So that's one issue. So we know now the standard. There was always a conflict about what age. We know now it's 40. There's no debate about it.
Right. Artificial intelligence is basically in everything, everywhere. And we are seeing more and more of it in healthcare. And I was reading that it has a role in diagnosis for breast cancer.
So I think in large population where you have numerous numbers of screening imaging to review, AI is there to probably reduce and pick up the lesions, which will further be transferred for a radiologist to review. But then you also have to look cost to benefit ratio. I mean, the cost of AI into the medical field now is significantly increased. But I think with time, where the AI systems become a lot more cheaper, I think it's going to be more readily available in the population.
Right.
So I don't think it's something that is readily available as yet, but more research is being put into it.
I mean, our MRI is AI powered, so we're getting there.
Awesome.
Slowly but surely, we're getting there.
Oh, nice. But again, with cost benefit ratio, it is going to increase, and it definitely is going to help with the burden. Because what we want to do is increase the number of patient screening. So we want a fast turnover and an ability to pick up lesions.
I think that's the important part.
Yeah.
No, I can't remember the numbers, but I think something around 20% of the population walk around undiagnosed with breast cancer.
Definitely is a big number because, again, we don't screen.
Yeah.
And what we know for sure in our society, that the cancers we pick up is not based on screening. It's based on a lump. And when you have a lump already, your stage is obviously a greater stage in comparison to other societies where screening is being used.
Sure. But let's stick a pin in this discussion because we're going to go to break. And when we come back, we're going to talk about how Medical Associates has decided to take on the screening pathway. Don't go anywhere. We'll be right back.
This carnival, Spirit Mass and Medical Associates are teaming up to deliver an unforgettable experience combining celebration and care. As the first hospital on the road, we're bringing our mobile unit and team of dedicated doctors and nurses to ensure your health is a priority. Spirit Mass revelers have exclusive access to our premium rehydration packages as an optional extra, designed for hangovers, immunity building, and energy. Spots are limited, pre-book yours early. For more information, visit our social media pages. Stay safe with Medical Associates.
Medical Associates Hospital is the most affordable MRI imaging center in Trinidad and Tobago. Patients have quick access to bookings and service, on-time appointments, high-quality, convenient, and fast scans. With $800 off all MRI scans, we guarantee we have the most affordable MRI service in Trinidad and Tobago. Medical Associates Hospital, #1 healthcare for the entire family.
Welcome back. So if you're now joining us, we were just talking about mammograms. So, Leron, we were talking about why the uptake of mammograms is pretty low across the country.
I think a lot of women, when they come, and the reason I ask them why they haven't done mammograms is because they're afraid of the pain.
It is painful.
Oh, why would?
Right. I don't know. I never had one in the 2D, but I've had the 3D. And I would personally, I didn't find it that bad, to be honest.
I think the older machines, to get the image, because they use X-ray, more of X-ray, not digital, they had to get more compression to get a better view.
Yeah.
Now, the newer machines, and I think rightfully with the tomosynthesis machine, is going to be less compression because it's more digital. So the pain should be rightfully less. And then, there are certain skill set by the technician to reduce these pain and discomfort.
It's not just pain, though. The way you have to contour your body to get in the right position can be really uncomfortable.
Yeah.
So it depends. I mean, everybody is different. Everyone's pain tolerance is different. Yeah. But I have heard that people have done both. The ones that are 2D versus the 3D, they've had less pain.
Yeah.
But I wouldn't say it's a painless procedure. So pain is one thing, but one of the other things is that people are, it's a myth. So maybe we should bust this myth.
Yeah.
Why everyone thinks that mammograms can cause cancer?
Because we believe that mammograms has radiation exposure, rightfully so. But if you look at it let's step away from the mammogram machine, just daily radiation exposure, the sunlight, the environment, the rocks, everything has some exposure, releases some sort of radioactivity.
True.
Just a simple flight from New York to Los Angeles, that is radiation exposure in that altitude. And that radiation exposure is almost similar to the radiation exposure you get in a mammogram.
Right.
During the course of the year, we get, I think we did the math before, it was about 7.5 times more than that one dose of radiation you get for just a yearly exposure to environment.
So really and truly, this is such a minute part. Yeah.
And there are standards, and that's where they are FDA, that's where they are boards that ensure that these standards are met.
Correct.
Ensure that radiation exposure is minimum and standardized.
So I think this is something that people should hear about, because I know what my youngest patient looked like.
Yeah.
How old is your youngest patient?
My youngest breast cancer patient, and breast cancers can be multiple different types, but my youngest breast cancer is a 21-year-old. Yeah.
That is incredibly young.
Yeah. And the problem with young patients having breast cancer is that the lump tends to go similar to what the benign non-cancerous lumps are. So it takes a while before they become diagnosed, because as physicians, and I think any issue, you should always look at yourself first before you look at the patients. And I think as physicians, we see a young lady with a lump, we already think in our mind it's something benign, because we don't expect breast cancer at this age group. But I think if you assess, and based on principles, you use triple assessment for any lump, you'll be able to pick up those outliers. And this 21-year-old is an outlier. I mean, I've seen the numbers increase now. I have 21, 25, 28, 31, 35. The numbers are increasing for younger patients.
Yeah, that's definitely true. And mortality is higher in that younger
For
group.
whatever reason, when the cancer in patients that are younger, the cancer are more aggressive.
Yeah.
It spreads faster, it's rapidly growing, and unfortunately, they get that type of cancer that likes to come back more aggressive. So it really, really is a really bad cancer when you're younger as well.
So let's spin off from that. Is there a genetic component that we should be worried about, particularly with the younger persons?
So definitely there are two main categories for causes for breast cancer. You have genetic or family history, and that's about 10% of breast cancers. And then 90% is
10%
sporadic.
in Trinidad or worldwide?
Worldwide. So in Trinidad, I mean, the standard internationally is about 10%, and 90% means it's sporadic environmental factors.
Yeah.
In Trinidad, we did our research somewhere in 2022, 2021, and we found that 13% of our breast cancers were linked to a genetic mutation.
So that's higher than the average around the world.
Yeah, definitely. We know that there are breast cancers are more affiliated. Certain types of breast cancers, like triple negative breast cancer, which is a special type of cancer, we find more in the Black population, if I may say it in that way, versus the other populations. And because of our Caribbean heritage, we have more Black African heritage, and
Yes.
that increases our risk for breast cancer as well.
Okay.
For example, when we spoke about young patients under the age of 50 should get genetic testing.
Yes.
So to know if you have a familial history or genetic reason for it, there are certain criteria that we fulfill to who get genetic testing. For example, if you're under the age of 50 with breast cancer, if you're under the age of 60 with a special type of cancer called triple negative, if you are diagnosed with 2 breast cancers at the same time, if you're diagnosed with 1 breast cancer before the age of 50 and another after the age of 50, if you have a strong family of ovarian cancer and breast cancer, if you have a family history of metastatic prostate cancer, if you have a family history of breast cancer as well as ovarian, as well as pancreatic cancer, all those things are linked.
So I knew about all of those, but I didn't know about the link to prostate cancer.
Yeah, the metastatic prostate cancer one, if you have a family history, because most prostate cancers, I mean, I'm jumping into another realm
Yeah.
now. Most prostate cancers, never really cause mortality or death. It's
Correct.
very slow growing cancers.
Yeah.
But what we find in Trinidad and in the Caribbean, our prostate cancers are very aggressive.
Yes, they are.
And they present with, and when we say metastatic, let's explain, that's where the cancer has moved from the prostate gland or from that primary site and spread to the bone, the lungs, the liver, the brain. So when you have metastatic prostate cancer, we know that one is linked to a genetic mutation as well.
That's incredible because really prostate cancer is seen only exclusively in men.
Yeah.
Whereas breast cancer has the
Yeah, there's a link.
both.
There's a link with BRCA.
Yeah.
One of the mutations that are linked with prostate cancer and breast cancer.
So I think more than anything else, the awareness is what's going to make the difference.
So we know that as a woman, your life exposure, your risk of breast cancer is 1 in 8. You know that the more mature you get, your risk for cancer increases. So it's always better to pick this cancer up early before it becomes symptomatic for a greater chance for cure.
Yeah. Okay, so let's get into the meaty part of
Yes,
this.
tell
Okay. What is Medical Associates doing?
So, I mean, first, they invested into a new machine, which is the standard internationally, which is the 3D mammograms.
Yes.
So, again, it's going to help us pick up more cancers. It's going to help us reduce the false positive rates and reduce anxiety. And then that is going to lead us into a pathway that we're trying to create, which I wouldn't say we're trying to create, which we have already established.
We've established this now.
That's going to lead to that investigation, which is part of assessment of anything really is history examination and then radiological investigation. And the mammogram machine is a pillar of that.
Yeah.
And then that's the only recommended screening tool. Everything else is an addition. So you
Correct.
must have that baseline of a mammogram of screening at age 40. And then we do additional stuff like an ultrasound scan. And even better than that, we have even that more final niche of testing, which is called the breast MRI, which is also available at Medical Associates. And that has to be deciphered and picked up if it's required by a breast surgeon or a physician that has that practice in breast cancer.
So what would be the indication of using a breast MRI?
So definitely it's women who have high risk, meaning that they have a high risk of breast cancer. 2, sometimes women have very dense breast tissue, and they may be difficult to distinguish a lesion in a mammogram and ultrasound. 3, sometimes patients can have these occult breast cancers. They have sort of a cancer somewhere else in the armpit, and there's nothing visible on the regular imaging, such as a mammogram or ultrasound. So we do on a breast MRI. Sometimes when you're planning for surgical interventions, things like doing nipple sparing, sometimes you want to see the thickness of the skin to the breast. We do breast MRIs. Sometimes patients who had breast cancers have a strong family history. The risk is significantly high. We do maintain our screening with breast MRIs. But it's very, very particular to pick which patients to do MRI because we know breast MRI leads to a lot of more surgery sometimes
Yes.
because it picks everything up.
Yeah, that's true.
So it's not the first approach to screening.
Right.
Yes.
Let's walk this through. So we have a referral from the A&E department. I'm sending you a 38-year-old female who has come in and she's noticed she's got a breast lump.
Yeah.
And so I thought, okay, you're in clinic. Let me send her down. Tell me how we're going to walk this patient through our new pathway.
Yeah. So definitely what we're going to start with is a clinical history and examination.
Yeah.
Identifying, collaborating what the physician has diagnosed. And then we'll go to the pathway of imaging.
Yeah.
So, imaging modality for breast which is fully available at Medical Associates. We have our mammograms, we have the 3D mammogram, we have an ultrasound scan, and then we have the breast MRI.
Yes.
And we have a radiologist on board who's going to give us a report within a reasonable time, within that same time period, actually.
Yeah.
And then once we have completed the history exam and radiological assessment, then it's tissue diagnosis.
Correct.
And what tissue diagnosis simply means is taking a sample of that growth and looking to see if it is something that we are worried about, be it something malignant or cancerous or something non-cancerous. That's all we need to know within this 24-hour period of time. So how is that performed? Basically, it's a simple incision in the skin. We numb the skin. The incision or the cut in the skin is less than 5 millimeters.
Yeah, so there's no GA. I just want to say
There's
there's no general
This is
anesthetic.
done a same-day
It's-
procedure.
yeah.
It's done in the office. The patient leaves afterwards with no suture, no dressing. That's a simple dressing over the wound. So we make this tiny incision onto the skin. We use this special automatic gun, which takes a sample, and we cover the wound up with a dressing, regular Panadol for about 8 hours. Dressing comes off in about 48 hours. And within that 48 to 24 hours, we are actually going to have a diagnosis.
Correct.
We're going to have a pathologist on board to give us that report within 24 hours to know if it's cancer
And
or
that's
not.
pretty fantastic because I
Yes.
don't actually know anywhere else that has
Yeah.
that short turnaround time, which I think is really impressive.
I think one of the biggest issues is the anxiety.
Yes.
Imagine you have to go home and you're waiting a week. You're
2
waiting
weeks.
2 weeks
Yeah.
to get a report to know if this thing is cancer or not. I mean, myself, I underwent a surgical procedure, and having to wait that result within a week or two is something that is tremendously, difficult to overcome.
It's nerve-wracking. It can be so traumatic, actually.
Yeah.
So it's nice that we're trying to get that time frame narrowed down now.
Yeah.
So once, what I want to point out is once we get that diagnosis, it doesn't end there, and it's not one or two people. There is a whole team. We have a multidisciplinary team on board. So that's yourself. There'll be the radiologists, interventional radiologists. You'll have the medical oncologist, Dr. Capildo, and our radiologist.
Radiation oncologist.
Yes. So there's a whole team, and of course the pathologist as well.
Yeah,
I forgot to mention that.
Yeah.
But everybody comes together and has this meeting to have a discussion on what the best way forward is.
Yeah.
So I think that's nice because I think people think one person makes the whole plan. It's not like that.
Yeah.
There's a team of doctors.
I think that's international. So in my training in Toronto, that's called a multidisciplinary meeting.
Yes.
So we have the tissue diagnosis, and even more important, if we step back a bit, we're going to have the diagnosis of breast cancer or not. And then if it's breast cancer, we get to personalize that cancer because we're going to get a special test on that cancer to tell us the various antennas or receptors on it. So we'll know how your cancer is going to respond. And that's imperative, not just for the medical oncologist, but for the surgical oncologist. So you're going to have the surgical oncologist, myself. You're going to have the medical oncologist, as you mentioned, Dr. Capildo. We're going to have the radiation oncologist. We're going to have the pathologist. We're going to have the radiologist. And we're going to have the patient and their family interests, what they desire, what they want out of this. And we come together in a meeting prior to giving out the diagnosis, and we come with a basic rubric or plan for this patient within 24 hours.
Yes, and we will talk more about that when we come back from our break. So don't go anywhere. We'll be right back. Stay tuned.
Good day, my name is Dr. Laurent Olivier. I'm a breast surgical oncologist. Today we're going to talk about the breast mammogram machine. This is a tool that we utilize for breast cancer screening. It's the only recommended tool for breast cancer screening, which is actually what we call a 3D mammogram machine. Allows us the ability to take views of the breast at various angles, as you can see how the machine is moving left or right, and allows the computer to reconfigure a picture, a 3D picture of the breast. This allows us to pick up 25% more breast cancers and allows the false positive rate to be reduced by 15%. What that means, the ability to pick up abnormality is actually more accurate than the previous mammogram machines. This machine is readily available at Medical Associates, and the standard of care, which is mammogram machines for screening, is now starts at the age of 40. With the 3D mammogram, it allows us the ability to pick that abnormality and diagnose patients for breast cancer.
Welcome back. So we're going to talk to you about the surgical options available to a person that has been diagnosed with breast cancer. So, Laurent, let's break it down because there's two major pathways we could go. Yeah.
I mean, there are two main ways that you can deal with the breast cancer. But, just moving away from that a bit, most patients will come, doc, do I need to remove this lump? Do I need to remove the cancer? Can I have treatment and I don't need to have surgery? Surgery is important for two reasons. One is to remove the focus of cancer. And two is also to give us that pathological staging, that actual stages where we could categorize you in what stage where your cancer is in terms of its size, if the lymph nodes are involved, and that's important for your management. So the surgical management can either be where we preserve the breast or we remove the breast. I think we have all grown up hearing relatives saying that they have to lose their breast for breast cancer. That's not the standard anymore.
No, and that's a very traumatic, painful, and a deterrent, I actually think, for breast surgery.
Yeah. So that's why this is important. We need to let patients know that there are options.
Let's break it down for them.
Right.
Because you've got the reconstructive pathway.
Yeah.
So let's go down that first.
So let's talk about breast conservation. So breast conservation could have a reconstructive element, and that's called oncoplastic surgery, where we're using the same breast tissue or tissues around the breast to recreate a breast, and that's where you preserve the breast. And then you have the mastectomy, where you remove the breast.
Yeah.
You have different types of mastectomy, and then each type of mastectomy will have different reconstructive elements. So in terms of the mastectomy, you could have a simple mastectomy, where you remove the skin and the breast tissue. You could have a skin spare mastectomy, where you remove the breast tissue and you save some extra skin. You could have a nipple spare mastectomy, where you save the skin envelope, you save the nipple, and you remove the breast tissue.
Right.
In patients who have a simple mastectomy, they generally will have a delayed reconstruction, meaning that they're going to have a reconstruction after the treatment.
Okay.
So they can have that reconstruction delayed. And patients who have skin sparing and nipple sparing, you have preserved the skin, you have preserved the nipple, you allow the option of doing immediate reconstruction. But generally, the consensus is that we prefer to do immediate reconstruction once you are candidate for it, because you get the best cosmetic outcome.
I was going to say, because if I delay treatment until after I have, let's say, chemotherapy or radiation, does that not affect my skin integrity?
Yeah, and so definitely, not only that, besides the skin integrity, also you have certain, the base of the breast, the inframammary fold, the lateral aspect, all those things can be preserved to give you the breast shape and symmetry of the breast. So in terms of the immediate one, you have a nipple sparing mastectomy, you have a skin sparing mastectomy. And when you do immediate, it can be 1 stage or 2 stage. What I mean by that, a 2-stage reconstruction is that we remove the breast tissue, we preserve the skin, we preserve the nipple, we put a balloon in.
Okay.
Allow everything to heal, and then we stretch that balloon up to the size that the patient desire, the size of breast that the patient desire, comparable to the other breasts.
Right.
And then, after they have completed the treatment, what we do is remove that balloon and we put a permanent implant. So you can see it's 2 stages. So the first stage is removing the breast, removing the cancer, putting in the balloon. The second stage, after treatment is completed, you complete the reconstructive element and you put a permanent implant.
Okay.
Versus a 1 stage is that we remove the cancer, we preserve the skin, we preserve the nipple, and we put the permanent implant 1 time.
Okay.
How do I determine that? It depends on the quality of the skin, depends on what is available at that time in terms of preference of the reconstructive element.
Okay, and what are the risks of going ahead with that 1-step reconstruction rather than 2
So
steps?
the 1-step reconstruction, again, it depends on the skin quality, because sometimes if it is that you have that significant tension of the implant, it could affect the integrity of the skin, integrity of the nipple. It also depends on where you're placing the implant as well. So one of the benefits of it is that you can get that completed surgical procedure in one go, but also sometimes when you have additional treatments such as radiation, you can get a bit of tightening of the skin. So sometimes the 2 stages allow you to get that better refinement in the second operation after treatment.
Let's talk about breast conservation, because if you're taking away a section, a proportion,
Right.
there's going to be a level of asymmetry, right?
Yeah. Well, I mean,
How do we address?
when I approach a breast cancer, my goal is not just to remove the lump, but it's to maintain shape and symmetry with different approaches. As much as possible, I will try to hide scars. So ways to hide scars is incisions in the armpit, incisions beneath the breast, incisions around the dark area or the areola of the nipple,
Right.
versus going directly onto the skin. There are certain scenarios where I will have to go directly into the skin. Obviously, if the cancer is coming to the skin, if it's attached to the skin, then the skin needs to be removed.
Right.
But in terms of oncoplastic, we try as much as possible to maintain shape and symmetry. And shape and symmetry can be accomplished by shifting breast tissue around, depends on how much breast tissue you have, versus also doing things like a lift technique, with lifting the breast, where you do a reduction technique, so that you sort of incorporate where the cancer is, where you do a reduction.
Okay, yeah.
Or you bring flaps. So I do a lot of regional flaps, where you bring flaps into the defect.
So
to-
I think
to create
you'll
that
need to
symmetry.
define what a flap means,
Yeah.
because not everyone's going to understand
Yeah.
that.
So a flap is where you bring some tissue that was normally in a particular location,
Yes.
and I swing that tissue. And tissue can be fatty tissue, it can be a bit of the underlying of the skin,
Yep.
and sometimes even muscle. You bring into an area to give you that effect of filling that void of volume with the subcutaneous and fatty tissue from the flap itself.
Great. And so when you do that, that reconstructs the shape that's similar to the opposite breast.
Definitely.
Fortunately, that's all we have time for today.
Definitely.
Thank you for being my co-host.
Thank you.
And we hope to see you again soon. Thank you for listening, and I hope we have emphasized the importance of screening, what happens when you're diagnosed, and what kind of treatment options there are available to you. And we really hope that you will go forward and go and get yourself screened, encourage your family members to get screened. And I'm not just talking about women, men, I'm talking to you too. So we look forward to seeing you and serving you at Medical Associates. Take care until next time.